Okay, osteoporosis. There are a lot of risk factors for osteoporosis, especially for women, and these include being over 65 years old, postmenopausal status, smoking history, and a family history of osteoporosis. When women have osteoporosis confirmed with a DEXA scan and a T-score is less than or equal to -2.5, or with osteoporotic fragility fractures, this actually warrants for pharmacological anti-resorptive therapy. Any initial management for these patients would include having regular weight-bearing exercise and the avoidance of tobacco, excess alcohol use, and also having adequate intake of calcium and vitamin D. You also use these supplements only as needed. If you have normal levels of calcium and vitamin D, these are not necessary. But when it comes to pharmacological anti-resorptive therapy, the first-line therapy for most patients are biphosphonates. This includes aldendronate or risendronate. Biphosphonates are really helpful because they preserve bone density and they decrease the risk of vertebral and hip fractures. After you do the biphosphonate therapy, you want to check the DEXA scan in 2 years. But after 5 years, remember that most experts will actually stop the biphosphonates because you have an increased risk for atypical fractures with a prolonged use. When you're educating your patients on oral biphosphonate therapy, remember that they have to take this without any food or beverages beforehand. The reason for this is biphosphonates are very poorly absorbed, and when you take them with food or beverages, you create complexes that cannot be absorbed within the body. You also don't want to recommend oral biphosphonates with anyone with renal impairment. Remember that it doesn't need to be taken just orally, it can also be taken parenterally. Another treatment that you can use, but this is not a first-line therapy, is a monoclonal antibody called denosumab. It's an antibody that is used against the RANK ligand and can also be used in hypercalcemia of malignancy, and really is used as a systemic therapy to treat certain bone tumors, but can also help in the treatment for osteoporosis. The risk that you run with these monoclonal antibodies is a risk for infection and skin reactions. Lastly, anabolic agents can also be used, like teriparatide, in very severe cases of osteoporosis. Teriparatide is a PTH and PTH-related protein analog. It increases osteoblastic activity and increases bone growth. But because calcium levels can go up too high, you want to check serum calcium, uric acid, and of course renal function. Nasal calcitonin can also be used for osteoporosis. It does have a modest reduction for fracture risk, and it reduces pain from having old fractures from osteoporosis. Lastly, you can use selective estrogen receptor modulators. This includes drugs like raloxifene. It's a lot less helpful than biphosphonates, but you can also lower the risk of breast cancer. But it does increase the risk of DVT because it is an estrogen receptor modulator.